I'm Tom Bleck, and I'd like to welcome you to the session on the history of coma in 15 minutes, from Hippocrates to the here and now. I have no relevant disclosures. A few words on etymology. Coma comes from the ancient Greek coma, meaning a deep sleep. Carotid was derived from the word charis, meaning to plunge into a deep sleep as from compression of both carotid arteries. Obtun comes from the Latin obtundere, to dull or to deaden. Prior to Hippocrates, several authors were aware of the condition we now call coma. In Mesopotamia, a scholar wrote that someone who had been sick with a mighty illness for 5 or 10 days, whose pupils persisted in moving downward, would die on the 3rd day. Several conditions in the Edmund Smith surgical papyrus were associated with unconsciousness. Although it was not clear that there was a word for coma, the Egyptian word that was closest was used to denote both paralysis and unconsciousness. This hieroglyphic suggests that the literal translation was, "I did not know myself," as used for "I lost consciousness." Hippocrates described many cases of coma and associated the traumatic ones with the brain. He commented that the majority of cases require trepanation, but that you should not trephine the sutures themselves. He also described many comatose patients in his treatise on epidemics, but in many, the connection to the brain was not clear. However, in 16 of them, he yielded the final diagnosis of phrenitis, or brain inflammation, and most of them died. The 4 humors in Hippocratic medicine included blood, yellow bile, black bile, and phlegm. Apathetic behaviors were thought to be caused by an imbalance of phlegm, but coma was caused by too much blood in the brain and could be treated with venesection, which is a process that will be carried through for many thousands of years. Galen suggested that the brain controlled both cognition and action, and he demonstrated that the brain controlled respiration in animal experiments. He also believed that coma could be produced by pressure on the brain, especially in the area of the 4th ventricle. This illustration suggests some of the ideas of Galenic times regarding a substance they called pneuma, which was thought to be developed between the lungs and the heart and the brain, and as a consequence was responsible for controlling consciousness and action. You can see the consciousness line leading into the 4th ventricle. Wilder Penfield commissioned a cathedral ceiling painting in the Montreal Neurologic Institute. You can see that there are many models by drawings of Golgi of neuroglial cells, but in the center is Ares the ram, which in astrological terms presides over the brain. Surrounding the ram's head, one sees a quotation from Galen where he refutes the Hippocratic aphorism that injuries to the brain are going to be fatal, because he said, "But I have seen a severely wounded brain heal." Several of Galen's predecessors had different ideas about what portion of the body was in control of rational behavior. Plato thought, for example, it was the entire head. You can see others who thought it was within the brain and others who thought it was in the chest. Between the time of Galen and that of Thomas Willis in the 17th century, very little was written that was new about coma. Authors of the time tended to just repeat what Galen had said. Willis described, in order of increasing severity, lethargy, coma, and charis, finally culminating in apoplexy, with he thought was in the white matter. Coma in general was, however, thought to be reflecting an imbalance of blood in the brain, again to be treated with venesection. Other authors in the 17th century also believed that venesection was important. Here in Rembrandt's anatomy lesson, Nicolaus Tulp is the anatomy demonstrator who thought that too much black bile was the problem, but since you couldn't get to the black bile directly, you should just treat it with venesection. Sydenham described coma in many cases of febrile illness. In the 18th century, Boerhaave began to characterize different levels of coma and try to associate them with, for example, fever or intoxication. Boissier de Sauvage was known for trying to classify everything within medicine, and he attempted to subdivide coma according to genera and species in a very extensive publication. He also began to separate neurologic from psychiatric disorders affecting consciousness. Cullen defined apoplexy as affectation of both the powers of senses and of voluntary motion, but sparing respiration and the action of the heart. So he described a progression in his notions of charis to cataphora to coma and the lethargis. Starting with Chain in the early 19th century, there was a tremendous growth of interest in the description of both types and causes of coma. Some, like McEwen, thought that coma with supratentorial lesions resulted solely from cortical dysfunction and were not particularly enthused about invoking problems with the brainstem. This major publication by Chain lays out much of what was known at the time in both the anatomy and the clinical manifestations of coma. Others in that period began to focus on respiratory patterns. Charcot wrote about this, but was otherwise quite silent on issues regarding coma. Gowers, however, published extensively about coma, distinguishing stupor and obtundation from coma, describing changes in the pupils and in corneal reflexes. He also performed some experimental studies on dogs to try and understand the anatomy of coma. Osler was one of the first to discuss lateralizing findings in comatose patients as a predictor of the pathology producing their change in awareness. Duray pioneered experimental studies of coma and of course is well known for the brainstem hemorrhages that are associated with downward movement of the pons. Van Leyden observed in dogs what we now would call Cushing's triad. Both Pierre-Marie and Desjardins independently described coma vigile, we now term for the vegetative state. Cushing's experimental work looked at the relationship between changes in intracranial pressure and cerebral blood flow. He attributed coma to anemia involving the medulla due to compression, and also explored the effects of herniation on consciousness. The major breakthrough occurred in the 1930s when Remy described both cerveau isolé and encephale isolé, which correspond to what we now consider decortication and decerebration. The more cephalad lesion produced what he called drowsiness, which we would now associate with stupor and coma, whereas the lower lesion did not change the animal's level of awareness. And here the lesion appears to be between the midbrain and the pons, so it's not exactly clear how much of the reticular formation here is actually involved in the lesions that were made. Wilder Penfield was more interested in what went on in consciousness, in conscious patients, which is perhaps understandable in that much of what his work consisted of was mapping the brain and doing resections for epilepsy under local anesthesia. So he's able to notice that there were areas in which seizures produced changes in autonomic function, which he noted was in the area of the hypothalamus, and thought that adjacent structures in the midbrain were important not only for consciousness, but also for posture. He thought that this was really a general area and not necessarily a punctate center, and reported that this exact position may be wrong, but the reasons for searching for localization are valid, and we are still searching for them today. This very useful publication summarizes different both clinical and EEG consequences of various lesions. We've already discussed the cerveau and encephale isolé models. Lindsley and colleagues recording EEGs in animals at the time lesions were made and were keeping the animals alive, later noticed that a lesion here, basically disconnecting the midbrain and the pons, appeared to produce coma on the EEG, whereas a lower lesion that spared the pons did not change the EEG. Both Rossi and Bettini and their colleagues looked at lesions of the pons above and below the trigeminal complex, suggesting that this could predict whether or not coma would be produced on their EEGs. People began looking at areas in the brainstem that might be associated with permanent unresponsiveness, culminating in the groundbreaking studies of Parvizi and Damasio, showing that this area was most associated with unremitting coma after a brainstem infarct, whereas areas that were even more extensive but spared this region resulted in patients who eventually awakened from their comatose state. And Fisher again confirmed these, looking at changes in lesions in this same region. The phenomenal studies of Maruzzi and Magoon really opened our eyes to the role of the brainstem reticular formation in consciousness. They were really looking for changes that they associated with sleep and wakefulness. And later it became clear that what they were seeing was not just a change in sleep and wakefulness, but rather in awareness in the sense of producing stupor and coma. Nathanson and colleagues extended those descriptions to look at the changes in eye movements that could be seen in unconscious patients and how they might be reflected in anatomy. So in their 19 patients, they grouped them into those who had neither oculocephalic, so-called doll's eyes responses, or caloric responses, those in whom there was a dissociation such that they had no oculocephalic or doll's eyes response, but had disconjugate ocular movements with caloric stimulation, showing that there were either nuclear lesions or disconnections in some of the eye movement centers. And then other cases due to brainstem lesions in which there were disconjugate movements with both types of stimulation. This is Fred Plum examining the pupils of a comatose patient. Plum is really the great pioneer of our understanding of the anatomy and physiology of coma. In 1959, Plum and Swanson published a summary of changes in respiratory patterns they had seen in various central nervous system diseases, some, for example, in pontine infarction, others more extensive upper lesions. Polio was also an important interest of Plum's. So Plum and colleagues tended to put several different diseases together in their attempt to explain the anatomy of respiratory patterns, some of which have held up well, others of which have really different considerations now. We think of this not just in pseudobulbar palsy, but Cheyne-Stokes respirations really in bilateral frontal disease. In 1962, McNeely and Plum summarized the types of supratentorial multiple lesions that cause brainstem dysfunction. They described two syndromes related to these several cortical lesions producing either downward movement, rostral caudal deterioration, or what they called the uncle syndrome, which they attributed to movement of the medial temporal lobe down against the brainstem, pushing the brainstem toward the foramen magnum. Now notice that only 7 of their initial patients actually had this uncle syndrome. And also recall that these were being found at the autopsy table. None of our contemporary neuroimaging studies were really available to study this at the time. As a consequence, in their several editions now of the diagnosis of stupor and coma, Plum and Posner published a tremendous amount of material that has stood the test of time, but there are some things within it that are perhaps no longer considered correct. It's still really the Bible for people who want to understand what's going on. In this, they first described what they called the locked-in syndrome due to basilar artery thrombosis with pontine infarction. But it had been described before them. In fact, Alexandre Dumas, in his novel Account of Monte Cristo, described Mr. Nautier, who had very clearly the signs of a locked-in syndrome, which Dumas had associated with a hemorrhage, but in fact, we now know is most likely a consequence of someone having basal artery thrombosis. But the description, which runs for several pages, is really worth reading because it's a very classic way of understanding these patients. A few years later, in 1969, C. Miller Fisher published this tome in the Acta Neurologica Scandinavica supplement on the neurologic exam of the comatose patient, ensuring that both he and Plum are remembered as real pioneers in an understanding of coma. He classified patients who had persistent eye closure as having either drowsiness, stupor, or coma. Plum and Posner were also introducing obtundation. We try to stay away from these light, moderate, and deep coma terms, although they still appear in the literature. With the advent of CT scanning, Roper was able to show that many of the signs of herniation that had been attributed to compression of the brainstem were actually a consequence of horizontal shift of the diencephalon, dragging the brainstem along with it. That if you had progression of this, eventually you would see what McNeely and Plum saw at the autopsy table, but early on, you actually don't have compression of the brainstem, but rather horizontal shift, which is likely interfering with conduction between the brainstem reticular formation and the more cephalad centers that are necessary to have something driven in consciousness. As we move into the 21st century, we're now able to look at the different types of connections between centers, looking at DTI and other similar imaging techniques, showing that areas within the brainstem which have different neurochemical specificities normally have quite large ramifications up into the cortex, but as in this patient with an acute severe traumatic brain injury, there's been tremendous paring away of many of these structures, which not only helps us in explanation, but also leads to the possibility that the ability to stimulate some of the neurochemical systems involved in these brainstem centers may be able to help restore some cortical function. We can also use neuroimaging tools diagnostically, as well as for trying to understand the functional anatomy of what is producing coma. But these studies have also demonstrated something that was not known before, which was covert consciousness in a small number of patients who appear to be either comatose or vegetative. You can see here that in panel D, a patient is being asked either to imagine moving around within a house, or in the lower part of panel D to imagine a motor activity like playing tennis. And the areas to get increased blood flow are quite consistent in these patients, reflecting that in fact they are conscious and understanding what's going on. Now, this doesn't likely happen in a large number of patients, but we need to understand, both for the care of the patients and for understanding the ethical dilemma that may be produced by having patients who we think are unresponsive, who in fact do have covert consciousness. Some of our standard neurologic techniques can be supplemented by physiologic data easily obtained at the bedside, and with the use of machine learning can be coupled to understand in better specificity what's actually going on in these patients. And we can also perhaps use machine learning approaches to EEG to predict who is likely to recover consciousness in severely brain injured states. Again, the use of various functional MRI techniques like DTI will help us to understand in various conditions what areas are disconnected and what we might try to do to restore function. This review in Nature Reviews Neurology by Edlow and colleagues looks at a really up-to-date view of what's going on, stressing the problem with disturbed network function not simply of one center connecting to another, but how the centers interact. And as a consequence, what we might be able to do in terms of therapy for these patients. This has led to this three-dimensional diagram summarizing the ability to follow commands and to communicate on one axis to the consciousness that is recognized overtly as a consequence not only of the initial lesion, but also as improvement, but also looking at the ability to recognize covert consciousness either by functional MRI or by EEG networking techniques to try and really figure out where a patient falls in this area and what their trajectory is likely to be. So I'd like to thank you for your attention. These are some useful references in the study of the history of coma.